Myelofibrosis is a chronic malignancy that continues to have a suboptimal control with the current available therapies. The approved agents, ruxolitinib, has been in use for clinical use with patients for over 10 years, and we've seen some patients who have great benefit with it, but some patients continue to have suboptimal response. So our study was designed to attempt at improving the depth of response and the quality of response in patients on ruxolitinib. So hopefully they would have a more sustainable and more effective control of their cancer. So the study design was for patients who continue to be on ruxolitinib with an optimized dose, who have been on a stable dose for many months, at least 6 months, but continue to have suboptimal response as defined by an enlarged spleen, more than 10 centimeters, or enlarged spleen and persistent symptoms. For those patients, the intervention was to add on a variable dose of Parsaclisib, different dosing schedules and different doses, and a maintenance schedule in order to identify the best dosing schedule for Parsaclisib, as well as to characterize the activity of this agent. And we propose this design so that for patients on a stable dose of ruxolitinib, any additional benefit would be attributable to the to Parsaclisib, the intervention, and this way we can characterize this activity. Well, the key findings is that this combination is very safe, and at the dose level that is selected to move forward, there were very few grade 3 or higher adverse events. There were very few, if any, treatment emergent adverse events of special interest to PI3K inhibitors. There was very low discontinuation rate due to side effects. And most patients continued their baseline dose of ruxolitinib without dose reduction and continued the interventional drug Parsaclisib at the planned dose without interruption. So the combination was very safe. Many patients continue on study therapy on an extended protocol as we speak. In terms of efficacy, we have observed that the addition of Parsaclisib for patients who are already on an optimized dose of ruxolitinib resulted in further splenic volume reduction and further symptom improvement that was consistent in all patient cohorts. Some of those responses were quite deep. And we're very excited about these responses, especially that it was produced at different dose levels and different dose schedules. And based on that, this has generated 2 randomized prospective studies examining this combination in patients with myelofibrosis. That is a wonderful question. We have always been trying to improve the outcomes of our patients and the way we optimize the use of ruxolitinib. So hopefully once those studies are completed and the results are made available, the combination agents with ruxolitinib, especially Parsaclisib, can result in changing the standards of care in which patients with myelofibrosis are either offered a combination upfront in order to achieve a deeper, higher quality response upfront that would likely last longer, or this combination can be added on for patients already on ruxolitinib who continue to have disease-related manifestations. So hopefully this combination can be the way of the future in which patients with myelofibrosis are receiving more targeted, more effective combinations that can result in better clinical outcomes. And I would definitely like to advocate for enrolling patients in clinical trials. This is the ideal way for which we can advance the field and help more patients and their caregivers. We strongly encourage considering clinical trials for patients with myelofibrosis in order to advance the field.